Welcome to Decode Healthcare with Harshal. We're kicking off an elite 8-part explainer masterclass on the Respiratory System 3000 series. If you really want to master medical coding, you absolutely have to understand what the surgeon is actually doing inside the human body. So we're going to break these procedures down so perfectly that literally anyone could visualize them.
Today's explainer starts at the very top of the airway, the nose. Specifically, we're zooming in on the CPT code range 30,000 through 3999. The entire respiratory system is connected, from the nasal cavity straight down into the lungs. But today, we're just parking right at the front entrance.
Here is our syllabus for today: excision and foreign bodies, the big septosity versus rhinoplasty showdown, destruction and epistaxis, and finally, a quick look ahead at the accessory sinuses.
All right, let's jump straight into part 1, excision and foreign bodies.
The nasal cavity is basically our surgical theater for the day. This is where all the incisions and excisions are taking place. It's an incredibly intricate space, right? When a doctor is working in here, they're navigating a highly sensitive, very narrow corridor. Now, inside that corridor, doctors frequently have to excise, or basically cut out, nasal polyps. What's a nasal polyp? Well, it's just a painless, non-cancerous growth lining the nasal passage, kind of like small, soft grapes hanging down inside the nose. They aren't dangerous, but they do take up space, and that can make it incredibly difficult for a patient to breathe.
And that brings us to our very first coding rule. The CPT manual distinguishes the removal of these polyps based on the facility. You'll use code 31110 for a simple excision, which is normally done right there in an office setting. But you have to bump it up to code 3115 if the excision is extensive and actually requires the facilities of a hospital setting. The physical location and the severity absolutely dictate your code here.
Moving right along, let's talk about a super common pediatric scenario: removing foreign bodies. This is that classic code set for when toddlers decide to, shove a bead, a bean, or a little Lego piece right up their nose. Seriously, it happens every single day in clinics around the world. To code this one accurately, try to picture the scene. Code 30300 is the doctor in the clinic maybe using a simple pair of long surgical tweezers or a tiny suction device to just pluck that toy out while the kid is awake. Total office procedure. But what if the child is uncooperative or the object is lodged dangerously deep? Well, that brings us to code 30310, which means the procedure required putting the patient completely under general anesthesia in the OR just to safely get the object out. Same anatomical problem, completely different code based on the anesthesia and the setting.
Let's keep moving to section 2, septoplasty versus rhinoplasty.
This is a critical coding distinction within the repair section that honestly trips up a lot of students. But first, we have to define the nasal septum itself. Simply put, it's just that central structural wall made of bone and cartilage that perfectly divides your left and right nostrils.
That inner wall of nasal cartilage and bone is meant to be relatively straight, but if that wall is severely bent or deviated, maybe from a broken nose or just genetics, it physically blocks the patient's airway. They literally cannot pull air through that side of their nose.
So, the crucial point here is intent. A septoplasty, which is reported with code 3520, is a medically necessary procedure. The surgeon goes inside, contours or removes the bent cartilage, and physically straightens the inner septum just to restore normal breathing. Contrast that with rhinoplasty, codes 3400 through 3420. A rhinoplasty is what most people would just call a nose job. It involves changing the external shape of the nose by working on the lateral and alar cartilages or elevating the nasal tip. While a rhinoplasty can be reconstructive, it's very often cosmetic. So, the golden rule to remember: septoplasty fixes the inside function, rhinoplasty fixes the outside form.
All right, let's dive into section 3, destruction and epistaxis. Moving down our CPT manual past the repair section, we hit other procedures, specifically epistaxis. Now, epistaxis is really just the official medical terminology for a severe nosebleed. And we aren't talking about a minor trickle from dry winter air here. We are talking about a continuous, heavy bleed that just will not stop on its own and requires immediate medical intervention. To control epistaxis, doctors use methods that sound a bit brutal but are incredibly effective. The first is cauteration. This literally means the doctor takes a chemical applicator like a silver nitrate stick or an electrocautery tool and physically burns the bleeding blood vessel shut. The second method is packing.
This involves taking strips of gauze or special nasal tampons and shoving them tightly into the nasal cavity to apply direct, heavy pressure right against that bleeding wall.
Depending on exactly where that bleed is and how hard the doctor had to work, your codes are going to change. Code 30901 is for a simple anterior bleed, meaning it's near the front of the nose and the doctor used limited cautery or packing. Code 30903 is for a complex anterior bleed requiring much more extensive work. But if the bleed is deep in the back of the nasal cavity, you move to the posterior codes, 30905 for the initial deep packing and 30906 if they have to go back in subsequently to fix it again. Always code to the depth and the difficulty.
Finally, Section 4, a quick teaser on the accessory sinuses.
We've thoroughly covered the surface of the nose today, from simple polyp excisions to major structural repairs and stopping hemorrhages. But this airway masterclass is just getting started. To go further, a physician has to feed a rigid endoscope deep into the nasal cavity, past those turbinates we just talked about, to visualize the internal structures of the sinuses, because that is exactly where we are heading next time. So what anatomical secrets lie deeper within the skull? And more importantly, how in the world do you accurately code a procedure where the surgeon is navigating millimeter-wide hollow caves right beneath the brain? Make sure you join me for part 2 of this explainer series, where we're going to decode the accessory sinuses and conquer the notoriously complex endoscopic sinus surgeries. Massive congrats on starting the respiratory series. Don't forget to subscribe, keep your codebooks open, and I will see you in the next one.